Rosamond Rhodes is professor of medical education and director of bioethics education at Mount Sinai School of Medicine, where she oversees the medical ethics curriculum for students in all 4 years of medical school, for house staff, and 11 residency programs for graduate postdoctoral fellows in the biomedical sciences and for students in the genetics counseling program. She directs a program of faculty medical ethics education and collaborates with faculty members in a variety of research projects. Dr. Rhodes serves as a member of the Mount Sinai School Ethics Committee and IACUC.
That's IACUC, Institutional Animal Care and Use Committee.
Okay, and Dr. Rhodes is also professor at philosophy at the Graduate Center, CUNY. Beyond the teaching setting, Dr. Rhodes serves as a co-editor of the American Philosophical Association newsletter on philosophy and medicine and on the editorial boards of the international journals of the Cambridge Quarterly of Healthcare Ethics, Theoretical Medicine and Bioethics, Bioethics and Clinical Ethics. She has published over 125 articles and chapters on a broad range of issues in bioethics, including professionalism, justice, the doctor-patient relationship, decisional capacity, surrogate decision-making, research ethics, physician-assisted suicide, genetics, cloning, abortion, assisted reproduction, organ transplantation, psychiatry, and bioethics education. She also writes on issues in the history of moral and political philosophy, so we can hardly imagine a more distinguished guest than Rosamond Rhodes. So I would like to hand over the word to her now on the lecture, Living Organ Donors, Lessons About Autonomy, please.
Wayne, thank you for inviting me. I'm honored to be here. It's a pleasure. So this is a little bit an unusual presentation. Can you hear me? Yeah. Okay. So not too many years ago, about 7 years ago, we had a living donor death in our liver transplant program. So we do living donor liver transplantation. And in the United States, I'll just give you United States data. To date, there have been 4 deaths in a little over 2,000 living donor transplants. So that's 2 deaths per 1,000. So this is a very dangerous procedure. And when they do an adult-to-adult living donor transplant, from the donor, they take approximately 70% of the liver. So this is a huge surgery. After the death at Mount Sinai, our adult-to-adult living donor program was closed for about a year, and the state considered measures that would make the procedure more appropriate, more ethically rigorous, more attentive to patients. And one of the things they required is that every living donor see a living donor advocate. And they defined a living donor advocate as someone who knew a great deal about transplantation and knew a great deal about ethics. So I had been working with the transplant programs at Mount Sinai for a number of years. I don't know, at that point maybe at least 15 years. So I was familiar with transplantation. I had written several papers about issues in transplantation, and I was the person who knew about ethics. So this was before Nada joined our faculty, and so I was the only one at that time. And I got the job of being living donor advocate, and for 4 years, I was the only person doing this role. And I had to see every single patient who wanted to be a living donor. So these are healthy people. We're going to cut out 70% of their liver and give it to somebody else of their choosing for no good to themselves medically, putting themselves at risk of 2 in 1,000 deaths. So let's see, before that, I had twice taught seminars in autonomy. So every spring I co-teach a seminar with one of our physician faculty members, the chairman of our ethics committee, and we teach a seminar called Bioethics Policies and Cases, whatever we feel like teaching that year, and I usually get to choose. So twice we had done a course on autonomy. And I was familiar with the latest literature on autonomy. So this puts together my experience as living donor advocate and familiarity with the literature on autonomy, and it's a description of what I learned from being a living donor. So here we go. So basic principles of medical ethics are act for the good of patients, and you should avoid harm. This is for the physician, right? Now, when you have living donor transplant, the surgery certainly does not benefit the organ donor. In fact, they're put at risk. As I said, 2 in 1,000 die, but maybe 8 in 1,000 can develop a serious complication. And the complications have been so significant that there have been, in the US, through the history of this, 2 people who required liver transplantations after being donors. So that's 1 in 1,000. Okay. So the surgery certainly imposes harms, including risks of death and serious injury. Certainly you will have pain. You will be disabled for a while after you donate, not for very long, but for a few days. And to be fully recovered, it takes a few months. You'll have impaired function for a short period of time, and you'll certainly be mutilated, scarred, disfigured. So what justifies allowing people to be living donors? Well, from the donor's perspective, the organ donation achieves an important good. It saves the life of someone who is dear to the donor. And from the perspective of the donor, the anticipated benefits of saving the life of someone who's dear to you are worth the risk and the harms. And from the transplant program's perspective, this, if it's done carefully and with appropriate screening of the donors, the risks and harms are reasonable compared to the anticipated benefits. So to tell you a little bit about our screening program, before someone is accepted as a living donor, they have to see a whole battery of physicians. They have to have their heart checked and their breathing checked, and they get imaged from head to toe. They have to see the social worker, they have to see the psychiatrist, and ultimately, before any surgery is conducted, the battery of transplant surgeons and the radiology experts who do the imaging and the medical physicians, and I used to do it as well, and the whole team sits together and looks at every slide, and they consider the vasculature and the proportions of the liver and how it breaks up. So it ends up that typically 3 out of 4 people who come forward and say, I want to be a living donor, 3 out of 4 are rejected. So it's very carefully selected people end up being donors. If there's any risk that you can foresee in advance, they're ruled out. So with that careful screening, we think we're minimizing the risks, and it ends up being a reasonable procedure. You should also note that the liver regenerates very quickly. I was speaking to a doctor here in Belgrade, and I was told of an experiment they were doing with some liver cancer surgery. And the liver is actually regenerating almost completely in a week. We tell people it'll be a few months, but according to this new kind of surgery, it's a week. So it's pretty revolutionary. Okay. So the important ethical consideration that everybody recognizes is that organ donation should be voluntary. If it's not voluntary, we have problems. So what's a voluntary action? For your action to be voluntary, we know this since Aristotle, you have to have knowledge of the facts that are salient to this decision. There can be no deception and no force. And this idea of what is autonomy and voluntariness is originally a classical Greek concept, and it's largely, in its original forms, a political concept, and it has to do with civic communities being independent and self-governing. In the Renaissance period, it's a political concept as well, and it largely means independence from religious authorities. So first it's independence from other political authorities, then it's independence from religious authorities, and largely from the time of Kant, it's about independence in your personal action. So it's a moral concept today, and it's a characteristic, we think, that associated with rational beings who have the power of being good rulers over themselves, making rules for themselves that can guide their action. But we also see a tradition of this thought, certainly in the Stoics and Aristotle and Hobbes and Spinoza, of this Kantian kind of conception of autonomy. And it amounts to the ability, according to Aristotle, to take responsibility for your actions. So Aristotle talks about when you can praise or blame someone, which amounts to taking responsibility for your action. In Kant, autonomy is the ability to act from the moral law that one creates to govern one's own action. So it's, in these senses, it's an ability. And autonomous actions start being described in the most contemporary literature as actions that conform with higher order volition. So this concept comes from Harry Frankfurt, and Harry Frankfurt talks about the cigarette smoker or the drug user, and there will be the cigarette smoker who says, I love smoking cigarettes, it gives me great pleasure, I like watching the smoke of the cigarette curl up, and you still see people doing that in Belgrade, not so much in New York, but people take pleasure in it. And then there are other people who smoke cigarettes who say, I wish I could quit this habit. I wish I didn't have to spend so much money, I don't like the way it smells on my clothes, but I can't stop. So for Harry Frankfurt, the person who says, I like smoking cigarettes, I like watching the smoke, I feel I look very sexy when I smoke the cigarette, that person is autonomous. Their actions conform with their higher order wishes. I wish myself to be a person who smokes. The person who says, I can't stop smoking cigarettes, I can't help myself, I'm just compelled, I feel terrible if I don't, I have to get a cigarette, I have to get out of the room to smoke a cigarette. That person who wishes, has a higher order volition, I want to smoke now, but I wish I didn't want to smoke. That person, when they're smoking a cigarette, their action is not autonomous because their action does not conform with a higher order volition. So that's Harry Frankfurt's view. So I'm going to go through a series of contemporary philosophical conceptions of what is autonomy or what is autonomous action, and show you what people are saying now before I contrast that to my experience with the living donors. So Gerald Dworkin has a similar view to Harry Frankfurt's. An autonomous action is one that, after I've done it, I would have still wanted to do it. So if I ask myself today, Rosamond, you're putting, I don't know, you're wearing a blue jacket to this meeting that Voyen invited you to. Tomorrow, will I think that I've done the right thing? If it conforms with what I think I would have wanted tomorrow, it's autonomous today. So thinking about medical ethics, we have the example of the Jehovah's Witnesses. And the Jehovah's Witnesses are people who refuse blood transfusion. So you can imagine somebody who's brought into the hospital after a bus accident and they have lots of internal injuries and they're bleeding, and the doctor says to them, can I give you a blood transfusion to save your life? I want to give you a blood transfusion. Without it, you will die. And the Jehovah's Witness says no blood transfusion. So the doctor gives the patient today a blood transfusion, and the patient lives to see tomorrow because of the blood transfusion. Will the patient say tomorrow, thank you for having given me the blood transfusion? And what we expect with the blood transfusion is the patient today will say, I will be miserable tomorrow. And if they live to see tomorrow because of the blood transfusion, what they will say is, you ruined my life, you gave me eternal damnation. That is not what I would have chosen yesterday. So this idea of, is it what you would choose tomorrow, is Dworkin's conception of autonomous. If it's what you would choose tomorrow and you're choosing it today, it's autonomous. The opposite would be me and potato chips. So this is, I love potato chips. If you put down a bowl of potato chips, I keep eating till the bowl is empty. And if you ask me, I always say, well, I should be losing 20 pounds. I know potato chips are very fattening, but you put down the potato chips and I'll tell you all kinds of stories. I'm very hungry. I didn't have enough breakfast. I didn't have a good dinner. I need the potato chips to get through the lecture. But afterwards, I will say, I shouldn't have eaten those potato chips. You know, I always want to lose 20 pounds, and this is inconsistent with it. So my eating the potato chips today is not autonomous, because afterwards, it's what I wish I would not have done. So this Dworkin idea of autonomous action is, the action is autonomous if it's consistent with my future-oriented consent. Okay, so these are similar but slightly different. Then there's Christine Korsgaard, who also discusses this idea from a very Kantian perspective, and according to Korsgaard, an action is autonomous if it's the action that I reflectively endorse. So if I impulsively eat the potato chips, it's not autonomous, but if I think about it and say, I really need it, I feel like I'm going to faint without some potato chips and I can't faint in the middle of a lecture, then it's reflectively endorsed. I should fulfill my responsibilities and not faint in the middle of lecture, and then it's an autonomous action. Then there's Bernard Borofsky, who talks about self-authorization, self-realization, self-expression. So there's this idea of who I am, what I am as a self, and if it's consistent, the action is consistent with who I want to be, an expression of myself and the kind of person I want to be, then it's an autonomous action. David Velleman talks about identity as a self-narrator. So when I tell the story of my life and who I am, is this action consistent with this story? And then there's Marina Oshana, and she talks about an absence of alienation. So an action is autonomous if it's not the kind of thing that I feel, I did that, how could I have done that? So if I have that feeling of, that wasn't me, then it's alienation. So if there's no feeling of, I couldn't have done that, it's not me to have done that, I was rude and I think I shouldn't be rude. But if I can identify with the action, it's autonomous. So we have, these seem to be the major views on autonomy in the current literature. So my experience with living donors. So these aren't the real living donors, but I've just put up pictures to kind of orient us. So these aren't the real people. I'm not violating confidentiality. That's what I'm telling you. Okay, so some of the people would say things to the effect, and I took these quotes from my notes on my reports about the living donors. People would say things like, of course I'm afraid and would prefer not to do this, but this is the right thing for me to do. And in evaluating a living donor who says this, I have to give a report to the transplant program, is this living donor acceptable? And in my own thinking, I thought, what would make somebody not acceptable? Well, if their action wasn't voluntary, if they were not acting autonomously, or if they lacked some important information, it wouldn't be autonomous. So I wanted to assess, in some sense, were they acting autonomously? So could a person who said, of course I'm afraid and would prefer not to, but this is the right thing for me to do, could that person be someone who is acting autonomously? And this, of course, is very consistent with the idea of higher order volition. So, sure, I'm feeling afraid, but when I think about it, do I want to be afraid, or do I want to be able to get over my fear and do the right thing? So this idea of control of desire and higher order volition, it's perfectly consistent with autonomy and this Harry Frankfurt sense of higher order volition. Now, other donors would come in and say things like, I couldn't live with myself if I didn't try to save her. So this is a slightly different variation on the theme, and in effect, the person who says this, I couldn't live with myself if I didn't try to save her, is saying, if she dies tomorrow and I didn't step forward as a living donor, I would be miserable. If I saved her, or at least I tried, I put myself out there to be evaluated, I could live with myself. So it sounds very much like the Gerald Dworkin future-oriented consent. So here we have people who I'm saying are autonomous, and they're giving different conceptions of autonomy. A number of people, typically children giving to parents, and these were the ones that bothered me a great deal, would come out forward and they'd talk and talk and talk, and often in the course of their conversation they'd say something like, my family expects it of me. And I put up this photograph. I don't know if they look to you like a Serbian family or an American family, but to me they look like a very stern family, people you wouldn't want to cross. And would someone whose family says to them, whether they mouth the words or just give you the sense that this is an expectation, if your family is expecting this of you and you come forward to be a donor, is that an autonomous action? And thinking through it, to me it looks like the person who says this thinks, I ought to do the things that my family expects of me. I should be the kind of person who makes my family think I'm doing the right thing, makes me proud. It sounds very much like Course Guard would accept it as autonomy because it's reflectively endorsed. There are people, many people, who walk away from their families. And as long as the donor is free, physically free, to walk away from her family or conform with their expectations, I decided, and you could think I'm wrong, and I'd love to hear your feedback after we get through it. I decided that these people who were donating primarily because my family expects it of me, or my mother expects it of me, or my father expects it of me, I thought they were being autonomous. When people would say such things, I would frequently go back to them and say, well, imagine yourself 20 years down the line, and now you need a liver transplant. Would you expect this of your child? And I was shocked to see that many people said, of course I would. And to me, that's alien. But we're very different from each other, and I accepted it as being autonomous. Then there were the people who would come and say things like, I want to be the kind of person who helps people. And that just sang out as this idea of self-authorization, self-realization, self-expression, the Bernard Borofsky idea of autonomy. This is the kind of person I want to be. When someone's in need, I want to help them. No problem sounds clearly like autonomy. I accepted such people. One of the most interesting ones was a woman who came forward to donate to a member of her church who she barely knew. She knew about this other woman, that she needed a living donor and there was none, and she came forward. And what she said is, I am a Christian, and like a good Samaritan, I help my fellow man. And this to me sounded very much like that Marina Oshana concept of identity being a self-narrator and the absence of alienation. She's telling a story of who she is. I am a Christian. I help my fellow man. And then there are the ones, typically parents giving to children, and they came in and said things like, I have to. I can't do anything else. I have no choice. And what I kept hearing in my head were, what would another philosopher say, listening to somebody say, I have to, I can't do anything else, I have no choice. And could that possibly be autonomous? And to me, as a mother, it seemed like the most obviously autonomous choice of all, because what these words mean to me is I have goals and values, and among these I have priorities, and the top priority is what's good for my children. And if that's my top priority and my child needs a liver transplant, I have to. I can't do anything else. I have no choice. But these are the priorities that I'm most committed to, most identified with. So I think it's truly autonomous. So autonomy and voluntariness. Another way of looking at it is, in Marina Oshana's words, being in control of one's choices, actions, and will. And I think all of these people expressed that they are in control of their choices, their actions, and their will. But what I saw across the spectrum is not one single concept of an essential feature of autonomy being this. Think of people who have a simple view of genetics, like this is the gene for X. It works maybe with Huntington's disease, but it certainly doesn't work with common diseases like diabetes, where there are 10 or 12 different genes and we still don't fully understand the associations. There's a nest of concepts, and in a very Wittgensteinian way, it's a family resemblance of concepts that captures this idea, and that brings me back to this Aristotelian broad notion of voluntariness. Can you hold this person responsible for their choice? If so, the choice is voluntary, and it reflects some sense of autonomy, but there isn't one sense, it's a family of concepts. So, in case you didn't hear me, what I'm saying is all these philosophers who say, this is autonomy, they're only partially right. In effect, they're wrong, because this isn't autonomy, it's this nest of concepts. So the conclusion for living donor advocates is that the assessment of living donors by living donor advocates is an ethically challenging activity. It requires an understanding of voluntariness and autonomy to sort out when a decision should be accepted. But for philosophers, I think it's a little bit more complicated, because we have the concept of who has autonomy and who is capable of voluntary action. And in bioethics, we get two very different answers. So here we have the bioethicists coming into the medical ethics discussions, and we have the bioethicists when they're talking about a clinical ethics conception of autonomy. And you get people advocating that children, from as young as age 7, they have to give assent, you have to listen to what they say, you have to pay attention to them. In other words, we're saying autonomy extends to young children. But also we have people like Ronald Dworkin and Rebecca Dresser in their argument. And Rebecca Dresser, well, she's a lawyer, actually, but people in philosophy accept this view that even the demented can have some autonomy. So she talks about the happy demented person who used to say she didn't want to live, don't give me antibiotics if I should get pneumonia, I want to die. And then she's smiling and she's saying, hello, dear, and she looks like she's happy with her life. So it's, even if she can't say, I want to live, give me antibiotics for my pneumonia, this expression of pleasure with life, the bioethicists take as being something like autonomy that has to be respected, and even people with serious mental illness have to be respected. And we have now this whole new move of talking about people in minimally conscious states. So they can't, people who can't communicate, individuals who can't communicate at all. If you do some brain scans and you say, think about how you would get to your bedroom from the living room, and they have some brain activity that looks like they're the same as what normal people think of when they think of how to get from the living room to the bedroom, then there's something going on and they have to be respected. So in a sense, in clinical ethics, we're extending a concept of decisional capacity or autonomy very, very, very broadly. And with it comes all the baggage of respect for autonomy in the Kantian sense of we have to show respect, we have to give these wishes a place. And in America, not too many years ago, we had the huge debate over Terri Schiavo. Poor Terri Schiavo. She was in this vegetative state for years and years, but her family and the US Congress and the US President thought she had some kind of wishes that she was expressing, and they had to be respected, and she had to be kept alive. So we have this concept of autonomy, and the President's Commission on Bioethics was very much in favor of it, extending the autonomy very, very far. At the same time, in research ethics, we seem to have the opposite view. Certainly, no one who is vulnerable has autonomy because we have to protect them from decisions they would make for themselves. So this group of people includes children, the mentally ill, prisoners, pregnant women, the elderly, anybody who's economically or educationally deprived. So I think I'm in at least 3 of these categories, because I only had high school biology, so educationally deprived, economically deprived, I'll put myself in that category, elderly. So you're putting a lot of people in these categories of vulnerable, and then you have to protect them whether they want it or not. So you're saying they don't have autonomy to make decisions for themselves, we have to protect them. Also in research ethics, anybody who signs up for a research project, who then starts to think that this isn't research but it's treatment, those people too have to be protected because now they're vulnerable to the therapeutic misconception. So I was in the categories of vulnerable before, but I'm also in the category of therapeutic misconception. Years ago, we had a study of drugs for herpes simplex. So you get a cold sore, and they developed a drug for it. So I like to see what's happening in my institution, and I also believe we all have a duty to participate in research. So whenever there's a project that I qualify for, at least at my institution, I volunteer myself. So for this project, there was one about, do you get herpes simplex, and if so, will you be a subject? I volunteered, and I went, and you had to hear the informed consent, and they explained very nicely that you could get the active drug or you can get the placebo, and when you feel the symptoms of a cold sore coming on, you should go and they'll give you one or the other, and you take these things and you keep a record. and they'll try to find out if this substance works or not. So I got the itch that told me I'm getting a cold sore. I went and got the pills, and I took the pills, and I kept thinking, this medicine doesn't work at all. This is the worst cold sore I ever had. So I filled in my record, I told them when I turned it in, and I thought, that drug doesn't work. But 6 months later, I got the itch again, and I called up my doctor, and I said, 6 months ago you had this study. Have you found anything in the interim? And he said, sure, come on over, I'll give you something for it. We have very effective medication. And I went over, and he gave me the identical blue pills that I had before in the study. And it wasn't until that moment that I realized that I had been getting the placebo. So it was explained to me, I understood it, but when I was taking the pills, I forgot. I couldn't remember. I thought I was getting treatment. I was getting a drug that didn't work, as opposed to I'm in the placebo arm of a study. So I was vulnerable to therapeutic misconception, and the people who do research ethics would have said, she doesn't have autonomy, she has to be protected because she's vulnerable. The research ethics community also thinks anyone who's offered an undue inducement can't resist the offer. So if somebody says, we need subjects for this study, we'll give you $10 if you sign up, and I say, I'm not going. And then they offer $100 to participate. What the research ethics community is likely to say is that it's an undue inducement because it will force me to take risks, distort my judgment in a way that I couldn't otherwise. So they want to protect me from that. And they also, there's a new move of wanting to test people for their understanding of a study. So they want to, after you've gotten informed, explain the procedure for informed consent, that you have to take a test, and there are debates whether you need to pass the test with a score of 90% correct or 100% correct. And if you don't fully understand, you lack autonomy and you have to be protected. So we have in bioethics this extremely liberal view of autonomy that includes minimally conscious state and demented people. And on the other hand, this view of autonomy that's extremely paternalistic, nobody's got it, especially if you can forget that you're in a study for a few days. So the conclusion, I think, for philosophers is that the clinical ethics concept of autonomy is not the same as the research ethics concept of autonomy, and both concepts can't be right, and you have to find something in between. And that's it.